On this episode of Wardocs, we speak with physical therapist, researcher, and strategic leader, Army Brigadier General Deydre Teyhen. Deydre shares the important role that physical therapists play in the military health system, from garrison clinics to the tip of the spear, supporting warfighters and safely and efficiently getting them back to the fight. Dr. Teyhen talks about the history of the Specialist Corps and her current role as Corps Chief, explaining how the Corps is a critical combat multiplier, helping maintain and sustain a ready medical force and a medically ready force. She describes the incredible opportunities that physical therapists have in the military, which include advanced training in education, research, and leadership. General Teyhen explains some of her evidence-based leadership philosophy and how she intends to bring the joy and soul back to medicine. Find out more about Brigadier General Teyhen and our previous guests on our website, wardocspodcast.com. And make sure you follow Wardocs on your preferred podcast platform and subscribe to our Wardocs YouTube channel. I'm your host, Dr. Doug Soderdahl, retired Army urologist, and I'm joined today by my co-host, Major Lindsay Umlauf, active duty physical therapist.
Welcome to Wardocs, the military medicine podcast. This show brings you a first-hand, behind-the-scenes look into the mission, unique opportunities, and deployed experiences of the entire military healthcare team. From state-of-the-art hospitals in the United States to the most austere environments across the globe, Wardocs has you covered.
Today we're privileged to welcome the Director of the National Capital Region Defense Health Network, Army Brigadier General Deydre Teyhen, to Wardocs. Ma'am, thanks for joining us today.
Thank you for the invitation. I appreciate it.
What inspired you to become a physical therapist in the U.S. Army?
You know, when I was in undergraduate school at Ohio Wesleyan University, I knew I wanted to go into medicine, but didn't know exactly which field in medicine. During my childhood, we had a lot of kind of death and dying, and I knew I didn't want to deal with that when I went into medicine as much as I really wanted to help people with musculoskeletal injuries. And so I really fell in love with the concept of physical therapy. And then I went down to Fort Campbell, Kentucky for the day to figure out what it meant to be an Army physical therapist before I applied to the Army Baylor program. And literally, as soon as I left there, I knew the only thing I ever wanted to do was be an Army physical therapist based on the scope of practice that Army physical therapists have and based on how well they're leveraged on the battlefield and how much of a part of the team they are as physician extenders in the military setting. And I was sold. I literally was like, I don't want to apply to any other program. I just want to be an Army physical therapist. So it was being able to spend a day at Fort Campbell, Kentucky that kind of sealed the deal.
For our listeners who may not be aware of the history of the Army Medical Specialist Corps and Army Physical Therapy, can you kind of tell us a little bit about the transformation of the Corps and the profession of physical therapy, let's say going back to World War I, early 1900s?
In World War I, we started off as reconstruction aides. We were all women. And at the end of World War I, they kind of didn't need us as much. And then as World War II started to ramp up again, we ramped up with World War II. At that point in World War II, again, from World War I to World War II, we were reconstruction aides and we were all women. And they decided to actually commission us. It was President Truman, 77 years ago tomorrow. Decided to actually commission PTs, OTs, and dietitians. But there wasn't a corps that we could go into because the Medical Service Corps by law was only allowed to have men. So we created the Women's Medical Specialist Corps in 1947. And then not even 10 years later, they actually adjusted the law to allow men to join our corps. And then we went to the Medical Specialist Corps. And tomorrow will be our 77th anniversary. And so when you think about our professions, what's really interesting is they all started in the military and then moved into civilian world afterwards. And so really the profession itself started because of the U.S. Army and the need that was seen in World War I. What really kind of set us apart and kind of really changed our trajectory was Vietnam. And in the Vietnam War, there was such a need for folks to assist and extend the effectiveness of our orthopedic surgeons who were spending so many hours in the OR that they actually needed to have their physical therapists work at the top of their credentials and be their eyes and ears out in the combat support hospitals at the time. and be able to understand how to care for those folks and help triage them so that when the surgeons was done with their last surgery, the next surgery would be kind of teed up, and then the post-op care was really done by the PTs. And at that point, we really became physician extenders, and we actually progressed our scope of practice at that point, which we've been able to continue to do primary care physical therapy since then.
So tell me a little about the other services. So that's the Army. In the 40s, we're transitioning from the Army Air Corps, Army Air Forces to the Air Force. The Navy's around. Where do you find physical therapists in the other services?
There is physical therapists in all three services, and they're in different corps. So in the Air Force, they're in the biomedical services corps, and then in the Navy, they're in the medical service corps.
So, ma'am, you mentioned that the 77th anniversary is tomorrow. So as of this recording, that would be April 16th, 2024 is the 77th anniversary of the SP Corps. So where would we find a physical therapist on the battlefield today?
I think it's really interesting how the career in the profession has evolved over time. Before, we would just be at the level 3, role 3 combat support hospital type facility. But today, we are been pushed far forward on the battlefield, integrated into brigade combat teams, integrated there just as not just a brigade physical therapist, but part of their holistic health and fitness team, which allows us to really optimize soldier performance, soldier health, prevention, and treatment of musculoskeletal injuries.
So tell us a little bit about your kind of early assignments. What kind of things were you doing, and what kind of lessons were you learning that helped shape the trajectory of where you are now?
My first assignment after Army Baylor was to go to Fort Hood, and I felt now called Fort Cavazos. But I was so lucky to be able to go out and support a division right away as my first assignment. I really learned what it meant to be an Army physical therapist supporting a division, and really being out there, understanding that it's more than waiting for them to get injured, but really trying to think of the soldier holistically. And so I was very blessed to have an amazing mentor at the time named Karen Reed, probably the most efficient and effective physical therapist I've ever worked with. All of us lieutenants and captains were trying to actually see more patients than her in a month. And while she led the clinic, she always saw more people than us. She led from the front. She showed us what it meant to actually be a leader and a clinician at the same time. And then from there, I went to Walter Reed. And so I went to be able to see from a division to a medical center and see what it was like to be a physical therapist at a medical center. And then I went to Kimbrough Ambulatory Care Center. And all three of these assignments really taught me that I loved being a clinician. I loved being an Army physical therapist. And then at that point, they actually invited me to go back, and I applied to get my PhD and was accepted. And so then after my PhD, I went on faculty at Army Baylor. And then I actually fell in love with being an educator and a researcher. And what's interesting on both of those is at the time, I never thought I would do anything different, right? I thought I'd be a clinician for the rest of my time in the Army. I loved being a clinician. And then the Army opened up another door. And then I loved being a researcher and an educator. And I thought I would do that until I got out of the Army. And so my start of my career was very powerful in making me understand the value of evidence-based medicine, and really the value of pushing that far forward to help America's sons and daughters who serve our nation.
So you've briefly given us an overview of your career and all the different areas that you provided care. Do you have a most challenging or memorable case that you've managed as a PT? And what were the lessons learned that you took from that?
I think the most memorable case is probably a series of cases, and it had to be my first deployment to Bosnia. And I was the only physical therapist, and I was the first physical therapist to deploy to Bosnia. And the number of people in pain and not having access to the care was significant. We didn't have a lot of resources because it was all about ingenuity. How do you actually care for these individuals? And what I quickly realized is that the biggest threat at the time was mines on the side of the road. And if you can imagine Bosnia at this time at winter with snow, and the fact that the farmers would find these mines and take them to the road, and then it would snow. And so they were very hard to see. And so soldiers had to be incredibly vigilant to see these mines that were put on the side of the road to be able to make sure their convoy was safe. And if they were in pain, they obviously weren't able to fully focus on the safety and security of their 4-vehicle convoy. And so it was really that opportunity that made me realize how valuable physical therapists are in a deployed setting. And it wasn't one case, it was a series of cases on that deployment that made me realize just how important it was that our soldiers weren't in pain when we were asking them to actually do the work of our nation in a deployed setting, and that we had to be there to help keep their pain level down or treat or minimize their pain or get rid of their pain so they can focus on the mission. And that required a lot of ingenuity because you couldn't just go to a supply closet and have all the supplies you have stateside. You had to really use your brain, your hands. You had to really think outside the box. And at the time, the people sitting in the crew served weapons space were basically sitting either on ammo cans or they were sitting in a sling. And so they were having a lot of back pain. And so what we were able to do is actually think, okay, what's the better setup so that they can actually sit in that, have their back supported while they also provided the vigilance required to keep their crew safe. And so really, I think that got me excited about research again, because you were actually kind of thinking through how do you make this better for everybody and not just the individual in front of you seeking care. How do you make it better for every single soldier deployed?
So you mentioned research, and one of the things that we see now is there's a lot of technology, there's artificial intelligence. Where do you see that impacting the specialty of physical therapy? How does that technology help you do what you want to do, especially in the battlefield?
I am really hopeful for what AI is going to bring to us clinically, but probably in a different lens than the question and how it was asked. I think it's incredibly important that a provider and a patient connect and connect in a way that the patient and the provider can really hear the patient. I had the luxury of remembering when they first put a computer on my desk at Fort Hood, Fort Cavazos now. And we wondered, why did we have to clear out our desk to put a computer on it? What are we going to do with a computer while we see patients, right? And what I've seen over my 30 years as we've become more reliant on electronic health records is that we oftentimes lost that ability to truly connect with our patients because sometimes people are plugging away on the computer as the patient's talking to keep the note up. So what I'm really excited about in AI is the ability for AI to actually be in the background listening and helping write the note so that the provider and the patient can get back to connecting and having a conversation. I was in a meeting the other day where they just rolled this out at a civilian hospital, and they told 2 stories. I'll share one of them, in which they were actually having a conversation the first day the person had AI, and the patient's corner of their mouth started to droop in the appointment. And it was actually a new onset stroke, and the person wasn't in there for that. But the provider actually could see that initial sign and symptom of a stroke and made a huge difference. And the provider said that if I didn't have AI and I was actually typing on the computer, I would not have picked up on that subtle sign. So to me, what I'm really excited about AI is allowing us to build trust between patients and their providers by allowing that engagement that we used to have that we took for granted before electronic health records.
Yeah, I agree with you. I think that the human touch, the human care aspect in medical care is never going to go away. I called that when that computer came into my office, I called it Jack in the Box medicine, where you just like, okay, the patients, you talk to the clown while I do the typing of your order. And it just drove me crazy. And I agree with you that I really hope that AI will get us back to providing that eye-to-eye human care and let AI do some of the stuff that we don't have to do. Now, was there a specific turning point in your career? You said that you loved the clinic, you loved research. Now you've got a star, and obviously that's a strategic level of leadership. Was there something that just said, boy, I want to go that direction?
When I was on faculty at Army Baylor, once you get on faculty at Army Baylor, you kind of stay on faculty to Army Baylor until you retire most of the time, right? And during that time, I deployed to Iraq. And we were at Iraq, and we had 6 different units put together off the Iranian border in Al-Qut, Iraq. And there was a gap of leadership that wasn't planned. And Colonel De Jesus was my 10th Combat Support Hospital commander. And he said, Deydre, I need you to lead this organization. And I thought, how am I going to lead this organization? I'm the busiest clinician. I'm the only physical therapist over here. And what I ended up being able to do was see patients in the morning, run the slice of the Combat Support Hospital in the afternoon. And then after dinner, I would see all the aviators when they came back from their mission for the day, and had a fantastic experience. And what I realized is, just as I fell in love with evidence-based medicine, I fell in love with evidence-based leadership. And I realized that how you lead people could actually make the whole system better for everybody. And if you made the whole system better for everybody, they all could thrive. And although you would think some of these principles are common sense, I have actually found out that they aren't so common sense on how to lead in a way that puts people first and lead in a way that allows people to thrive in their environment. And as soon as I got back from that deployment, there was an email that came out and said, do you want to apply for Lieutenant Colonel Command? And at that time, it was still relatively new that SP Corps officers could command at the lieutenant colonel level. And at the time, I didn't have an opportunity to command at the captain level. That just wasn't really an opportunity. And so I'm like, well, I'll throw my name in the hat. Why not? And boy, was everyone surprised when I got selected. And so the turning point really was that deployment, and realizing that the system issues that was kind of frustrating as a clinician, you could fix in leadership, and then make hopefully the whole environment better for everyone in the unit. And so it really was this passion to serve others on the team and make them enjoy their environment so that they can focus on the patients.
So jumping forward from your first command experience as a lieutenant colonel, during the COVID-19 pandemic, you served as the DoD lead for therapeutics for Operation Warp Speed at the Department of Health and Human Services. I imagine you faced several complex challenges during that time. Can you describe one key obstacle you faced, and what insights did you gain?
I'll start with the insights. The insight of the beauty of the interagency. I think the interagency was at its best during Operation Warp Speed. You had everyone working hard, trying to bring solutions out to Americans across the country. And I was lucky to be on the therapeutic team, and I started working with Janet Woodcock. And then Janet Woodcock got called up to be the acting commissioner of the FDA. And so there I was, right? As a physical therapist, trying to bring monoclonal antibodies and antivirals out to the American population. And I'm very proud of what we accomplished, and how quickly we were able to get those through the whole process and make sure that they were clinically sound for the folks. I think the biggest challenge was a surprise to me. As someone who loves evidence-based medicine, the question is, how much evidence is needed in a crisis for people to adopt a new technology? And it actually was much more complicated than I thought for people to embrace this whole new class of monoclonal antibodies that required ER physicians not to make the decision of, hey, this person's sick enough, we need to admit them, or they're not sick enough, they can go home, to actually identify a third group that was high risk based on risk factors and say, we're going to keep you in and do a monoclonal antibody infusion. And we're going to have to set up this whole infusion clinic, either in tents outside the ER or on a ward somewhere, so that we can actually prevent you from becoming an inpatient. And that kind of switch in thought process was much harder for people to adopt. The rural hospitals that were being inundated, they adopted it right away because they knew they didn't have any other resource, and they embraced it, and they saw amazing ability to save lives. I would say the more ivory tower academic medical centers, how much evidence did you need? And the challenge with that is, how much evidence would the FDA allowed to share before it actually was published in an article in a journal, which was embargoed prior to the publication of the journal article. So you had this kind of catch-22 where you had to work with professional societies, you had to work with NIH and FDA and everybody, and try to go around and convince providers and hospital administrators and organizations to invest in a treatment that has been proven to save lives. And it was very powerful for those folks that did it, but it was much more challenging than I thought for folks to embrace a new technology in a time of crisis.
You mentioned the interagency, and I think one of the things that listeners may not be aware of is how much the military actually did in Operation Warp Speed. What do you think? Is there something that would surprise people to know how much the military, what do they need to know of the military's impact in that operation?
Well, I'll tell you, it was an honor to work with General Perna. So General Perna was the lead for Operation Warp Speed with Monsef as the technical medical advisor. And what I think the DoD brought to the table is a couple things. One, our ability to plan and figure out sequencing, and how to actually streamline things and parallel process things to get to an end state. And then the logistical expertise that we bring to it. So, you think about the fact that it normally takes many decades to come up with a new vaccine. The fastest vaccine prior to Operation Warp Speed was 4 years, and that was the Ebola vaccine that the military worked on. And you think about the fact that actually almost, I used to know this percentage, but it's somewhere in the high 70% to low 80% of all vaccines actually had their start or had work on it by the Department of Defense, and mostly through the Walter Reed Army Institute of Research here in Silver Spring, Maryland. So that history gives us a lot of knowledge and capability, but no corners were ever cut during the Warp Speed. What was brought in is a new theory, a new way of looking at things, because in the past, and again, I just use vaccines as an example, if a new vaccine doesn't have a 40% return on investment, it's not really well perceived on Wall Street. So companies that invest in new vaccines are used to doing it systematically and slow, down selecting right away, and only continuing to invest in what's showing evidence early on. And what we were able to do with the DoD is parallel process things, actually not have to down select so early, so we could actually see how things played out and make sure that we kept investing in the fastest racehorse that was the safest racehorse and the most effective racehorse. And so you think about how we were able to do that. I don't think you could have done that without Department of Defense looking at the problem set in a different manner, because of how ingrained it is to just take one step at a time, analyze it, think about it, and then down select and go to the next stage. We were able to do a lot quicker because of a different approach in how we looked at logistics, how we looked at our R&D efforts.
In July of 2022, you became the first active duty general officer in the Army Medical Specialist Corps. I remember that day very clearly down in Blessey Auditorium at the Medical Center of Excellence on JBSA. That was such an incredible glass ceiling that you shattered. What were some key events or mentors in your career that helped prepare you to become a general officer?
I think there's 3 people that really made a huge impact on this. The first was when I was selected for my lieutenant colonel command. I was working at the Medical Center of Excellence, what we call it now. It used to be the AMED Center in school, and General Rubenstein was the commanding general. And at the time, I was selected for a lieutenant colonel command, but there was a decision to integrate the vet corps and public health. And so that lieutenant colonel command, they really wanted to make it an 06 command. And so, there was a lot of pressure to decline with prejudice and not take the command so they could put an 06 in that billet. And General Rubenstein sat me down, and not only did he encourage me to take the lieutenant colonel command, even though there was some a little bit of challenges with how they wanted to restructure that, but then he walked me through how to take that command and what do you do during the first couple hours of command, the first day, the first week, the first month, the first 90 days. And he really invested in someone that wasn't in his core, has never done an O3 command, and he just poured into me enough that allowed me to actually take his advice and run with it. And I'm forever grateful for how much time he spent with a young lieutenant colonel getting ready to take that command. And that was fantastic. But then I had the luxury of actually working for Major General Keenan, who was the Army Public Health Command CG. And so she was the first time I actually had a direct report of a general officer. And she really showed me the road. She showed me what it meant to lead people first. She showed me how you can accomplish the mission and take care of your people and really integrate all of that together. And then I would say the third person that really changed the trajectory and just allowed the opportunity was Lieutenant General Horoho. And I had the luxury of taking her vision of a system for health, transitioning Army medicine from a healthcare system to a system for health, her performance triad initiative, her move to health initiative, and really kind of being the lead for her in those efforts and really understanding how important a visionary leader is that gives inspiration that can actually change the trajectory of how an organization runs. And so those three, I would say, are the three leaders that if they weren't in my career, I would have not gone down this path. Then obviously since then, everybody that I've been able to work with has helped me, whether it's General Talley or General Holcomb and obviously General Dingle, and helping me get to this stage. But I would be remiss if I actually didn't talk about the fact that I'm only standing here because I'm standing on the shoulders of giants. All the other SP Corps chiefs that have paved the way from, 30 years ago, putting the first PT in a Ranger regiment, to putting all SP officers in a Ranger regiment, to the first PT in Special Forces, to all the SPs in Special Forces, to the Brigade PT and now Holistic Health and Fitness. That whole trajectory is the foundation that has allowed for the Army and Army medicine to want to have an SP Corps officer at the table. And then the other thing that I would say is, right now we have a reserve 2-star in the SP Corps named Major General Beth Salisbury, and she was the first OT and the first reserve SP officer to make it to general officer. And we just got Colonel promotable Bill Solis as a PA selected to be a general officer. And I share that because, General Dingle said, Deydre, it's not about being the first, it's about making sure there's someone coming behind you. So I'm very excited Bill's coming behind me. And then the other thing I would say is that to have all three of us selected around the same time, with Beth being selected in the reserves first, and then me, and then Bill, I think there's just a recognition that it's about getting our soldiers back to duty and actually optimizing their performance. And that piece is important to have that voice at the table.
So one of the things that I noticed over a 30-year career in military medicine is it seems like we're always in the process of transforming to something. And I'm sure that we're still in the process of transforming to something. What do you foresee the future for the Specialist Corps and maybe specifically physical therapy in the Army and in military medicine?
I like to look at this in the idea of risk to mission, risk to force. And Army medicine has and always will be really responsible to risk to force, right? Eyes, limb, life, eyesight, all those things, we have to be ready to have the back of America's sons and daughters when they get ill and injured on downrange, especially when there's catastrophic injuries, that we're there. And so we have a long history, as the Mayo Brothers says, the only victors in war is medicine. We have a long history of really advancing what we can do to save a life on the battlefield. When we come to LISCO, we still have to worry about risk to force, but we also have to worry about risk to mission. And what do I mean by that? If I don't have the golden hour and I can't medevac people out of theater, I also then can't reconstitute soldiers in theater to replace those that are ill and injured. And so there's a lot of think tanks, which I agree with, that says the nation state that can optimize return to duty is the nation state that will have the competitive advantage in LISCO. And that's where I think the SP Corps will be the secret weapon for Army medicine as we move forward, because we have the ability to really think about how to manage risk to mission by optimizing return to duty and thinking about what we can do to keep a soldier in the fight while they're ill and injured. And whether you're a PT, OT, dietitian, or a PA, there's a piece of that that allows us to do that that is unique to our AOCs. And that's why I say medical readiness starts with us in the SP Corps, because we usually work with soldiers outside the brick and mortar where they live, love, and labor. We're out there in their units. We're working with them in a way that builds trust, so that when they start to have a minor injury, they'll come see us before it becomes a major injury, and allows us to be able to be a partner with them so that they can stay in the fight. And I would love to kind of take through, and this started in 1996 when we put the first physical therapist in the Ranger Regiment. And at the time, the Rangers, if they went to Madigan, they usually returned with a permanent profile. And so Rangers didn't want to go to Madigan because they would come back with a permanent profile. Well, what they found out is they were waiting so long to get care that this was self-fulfilling, right? So that because they waited so long to get care, by the time they went to get care, it was a permanent profile, and it kept them from doing what they loved, which was being a Ranger. So they put the first physical therapist in the Ranger Regiment up there. And after building trust, they were able to see that long-term disability decreased and performance increased. And that's really started the whole 30-year trajectory that has led us to holistic health and fitness. So I think what we bring is the ability to mitigate risk to mission, while a lot of our folks have always been and should always be concerned about risk to force. And I think together, as we move forward, it's going to really help our Army win our nation's wars.
With the transformation of physical therapy and the Ranger Regiment all the way up to present day with H2F, the SP Corps is experiencing unprecedented growth despite nationwide shortages in healthcare personnel and strained retention rates. So what do you attribute this growth, and what are the lessons learned here?
So we are a Corps growing. And so we're growing to meet the needs of the Army for holistic health and fitness for our OTs, PTs, and dietitians. And then the PAs have a program in TRADOC called TOMS that's growing PAs to help support the TRADOC organizations and making sure people optimize graduation from, like, say, basic training in AIT. And so that growth has happened, and we've been able to hit every mark. And even when the Chief of Staff of the Army said he wanted to expedite the speed of H2F rolling out, I was able to easily say that the SP Corps had the officers required to meet that growth. And that's because I think, one, the recruitment is our education programs at the Medical Center of Excellence are some of the best in the nation. They're ranked by U.S. News and World Report. So if you want to become an Army physical therapist, occupational therapist, dietitian, or PA, our programs are the best in the country, and they get recognized routinely for how well they do. So that helps with recruitment. Also with recruitment, unlike medical school, there's not a lot of scholarships for allied health providers. And so the Army, Navy, and Air Force provide those scholarships. So that helps get people in the door. But what really excites me is every time I see the folks getting out, our folks really like to stay all the way to 20 years and retire or beyond. And that's because we get to do our mission. And I think because the Army allows us to work at the top of our credentials, and we get to actually do things that we can see the return on investment, and we get to work with the best patient population ever, soldiers and their families, right? And our veterans, that people stay because they love the mission. People stay because there's opportunities to go back to long-term schooling and education and training. There's opportunities to kind of develop, whether you want to go down really any type of path within those 4 AOCs, there's a way to do that in Army medicine. And so our retention rates are pretty high compared to some of the other corps. And I'm really proud of that. It's something we've been working hard on the last 4 years.
You're currently serving as the Director of Defense Health Network in the National Capital Region. And that's a big role. And it's something that is part of the MHS, the military health system transition. with Defense Health Agency and working with the services. What would you say are your key initiatives in this role, and what should people bring back to their organizations if they're listening?
If you go back to the last question and tie it to this question, my number one priority is to bring the joy and soul back to medicine. Number one priority. We really have to think about how to do that after COVID, where whether you call it a moral injury of COVID or you call it burnout, fatigue, resilience issue, however you want to label it, across the United States, people have lost the joy and soul in medicine. And these folks have worked really hard in many years to get their professional degrees to do medicine, whatever that career field is. And yet, across the United States and really across the world, there's people leaving healthcare at a higher rate than we've ever had before. And so to me, we have to create the joy and soul in medicine. And I want to really define what I mean by that, because I think people might think that this is all about potlucks and about social events that I'm talking about, and that could be not further from the truth. Although I do like a good potluck, what I really mean is about leaders at echelon that know how to invest in the people they're leading so that those folks can thrive, and that you create systems that allow everyone to thrive and excel in their workplace so that the joy, what brought them into medicine, they can experience again. And one of the things we talked about earlier is, as all this technology has come into healthcare, they're not really congruent. And so we've actually added a lot of administrative burden onto frontline providers who actually spend a lot of time to go to school to help people, and they're spending a lot of their time fighting systems that are incongruent and frustrating. Leaders at echelon have to actually make sure we find out what those providers' frustrations are and then work hard to get rid of those frustrations so that they can thrive. Initially, if you look back at the first time we tried to deal with provider burnout, we kind of thought, well, they're working too many hours, right? People thought people were superheroes in medicine, right? So maybe if we just decrease the hours in GME and limit how many hours they work, then they won't be burnt out anymore. Well, that didn't work. And so then there was this resilience point 1.0 where let's blame the victim. What really needs to happen is we just need them to have better resilience and they would be able to persevere and there'd be less burnout. And I am a huge fan of mindfulness. I'm a huge fan of resilience training, but that was not sufficient. And it was almost like you were blaming the victim for why they were burned out or why they had a moral injury or why they were frustrated with being in medicine. Resilience 2.0 is really realizing it's leaders and it's systems that you have to actually fix so that the providers and the support staff can thrive. And so when I talk about bringing the joy and soul back to medicine, it really is built on that. I'm sure everyone on this podcast has read Patience Comes Second or Beyond Heroes, but those are the books that kind of provide the philosophy of this. But it's the idea that leadership at echelon takes care of those seeing the patients, so those seeing patients can focus on seeing the patients and doing what brought them into medicine. I'd say the second biggest challenge is trust. And really, after 4 years of COVID and making sure people know they can come back into the healthcare facilities and get their preventive medicine checks, get their mammograms, get their colonoscopies, get that preventative health screening, and know that we're ready to see them and really that we're back to where we need to be, and building that trust with those that come into the direct care system is critical. Because the direct care system really is the center of gravity for military medicine. And because we need to create our own healthcare providers, from physicians to dentists to physical therapists to occupational therapists to PAs, that large graduate medical education program, that large graduate dental education program, that large graduate allied health education program only survives with a robust direct care system. So reattracting people back to the direct care system is really the fundamental goal, but you can't do that without first bringing the joy and soul back to medicine and building that trust so that you can build up the direct care system. And I'm incredibly proud because at Walter Reed, they were down after the war. They had to shrink a little bit as luckily we had less America's sons and daughters coming back, and we got down to about 119 staff beds. We're back up to 163 staff beds. Our goal is 200 staff beds at Walter Reed and 100 staff beds at ATA down at Fort Belvoir. And when we get to both 200 and 100 staff beds at both of those locations, we'll be able to recapture most of that graduate medical education. And really, then the direct care system is going to continue to thrive. It takes all of that to be able to get after that. And so to me, it's about the joy and soul of medicine and making people want to find what their why was and why they wanted to come in medicine, and that they can do that within our direct care system.
So pulling on that thread a little bit regarding bring the joy and soul back to medicine, what advice would you give to young medical professionals that are early in their careers?
I think there's a couple things. One is know your why, know what got you into medicine, what makes you excited about medicine. And although your why might adjust over time, that why is critical for the tough days, because there's going to be tough days. Muhammad Ali has a great quote, and it says, "It's not the mountains ahead of us that will wear us out, it's the pebbles in our shoe." Right? It's not the mountains we climb. We got into medicine because we know it was tough. We got into medicine because we liked the challenge. We got into medicine because we'd like to climb that hill, that mountain. And so understanding why you wanted to climb the mountain is critical, so that when the pebbles in your shoes accumulate, you don't forget your why and you can stay focused on the mountain that brought you joy. The other thing I would say is to bloom where you're planted, right? There's many times in my career that I thought I was supposed to go right and the Army took me left. And boy, that journey has been fantastic, right? And all the things I worried about on what career should I take, what's the next assignment, what should I do next? It all tends to work out because there's so many opportunities in the Army setting to really grow and develop your professional why while you continue to serve our nation. And so, whether you start off as a clinician and want to become a researcher, you want to become a scientist, you want to become an educator, or you want to become a clinical leader, there's ways to explore all of that within Army medicine. So understanding your why, blooming where you're planted, and not worrying too much about the future and just taking the current assignment and trying to invest as much as you can in that current assignment, and then allowing that to inform your why as you go into the next assignment, so that you can actually use that experience to decide what do you want to do next. Because the Army will always give you an ability every 2 to 3 years to figure out what do you want to do next.
So to that young military service member who might be looking at that mountain ahead of them and uncertain, whether or not they can climb it or can they truly bloom where they're planted currently, what advice would you give to that service member, whether they're an officer or an enlisted, who they're trying to decide whether or not they want to stay in the military?
That's an extremely personal decision for everybody. I personally am so glad that I've done my whole career in the Army. We had our 25th plus 2 reunion for all my folks in the Army Baylor program. It was 25 plus 2 because of COVID, so we had to wait a little bit to do our 25 reunion. And what was really interesting to me is there was the folks that got out early on, and they all actually regretted it later on. And as they looked at the folks that stayed to 20 years and beyond, they're like, I should have made a different decision. And so I would ask you to really think about your why and understand that why and reflect on it at those decision points and decide what is the right next step for you and your family.
So when the history books are written 50 to 100 years from now, how would you like them to record your legacy in military medicine?
I think there's probably 2 pieces of it. One, whether I was a clinician, I was a scientist, I was an educator, or now as a healthcare executive and a leader, I hope the folks that were in my organizations know that everything I did was focused on that top 1% of Americans who volunteer and serve our nation, that our focus has always been on America's sons and daughters and being able to give them the best of Army and military medicine. And at the same time, I hope those folks know, and I'm really proud of, how many folks in my units get to go on my enlisted that actually apply for to become an officer and get accepted in those programs, or the folks that actually apply for PhDs or long-term schooling, and that somehow I have helped them on their career so that they can achieve their why and on their journey. Because I do think it's always important to build the bench, build that next generation, and really invest and pour into those folks in your unit. Because not only can they serve in your unit and accomplish that mission, but you can help develop them on their journey for their why at the same time. And I really hope people know those two things, that the focus has been on how Army medicine and military medicine can best serve America's sons and daughters, while at the same time that we can invest and grow and develop everyone in our units on their journey to their personal and professional why, while they're also serving in military medicine.
Well, we've been speaking with clinician, researcher, leader, Brigadier General Deydre Teyhen on Wardocs. Ma'am, thanks again for sharing your experiences and insights with us, and thank you for your service to this nation.
Thank you so much. I sure appreciate the opportunity to be on Wardocs, and I appreciate all that you guys do to help tell the story of military medicine.
Thank you for listening to Wardocs. We sure hope you enjoyed it. Wardocs is a nonprofit organization supported by donations from listeners like you. Please follow and subscribe to our show on whatever platform you consume your podcasts, and rate and review this episode, and share the show with your contacts on social media. Find out more information about our show, our guests, and how to become a member of Team Wardocs on wardocspodcast.com. Thank you for your support. If you like war stories and medical drama, Wardocs has you covered. Spread the word.